Good evening, everybody. This is Tim Gibbs with Delaware Health Force and the Delaware Academy of Medicine and Public Health. Welcome to Delaware Mini Dental School, Winter 2026. This is our fourth session, well, technically our third because we skipped one. But anyway, we are glad that you are here. So this is a partnership between the Academy, our colleagues at the Sussex County Health Coalition, and for Mini Dental School with the Delaware State Dental Society. The YouTube streaming link is in the chat, or you can go to youtube.com/Delamed302. Remember, this is a Zoom webinar, not a Zoom meeting. We can't see you. You don't need to have your cameras on. You can't see each other. Please use the Q&A feature, not the chat feature, if you have any questions. When we get to the Q&A, don't ask questions of a personal nature, or if you forget, we will sort of de-identify so that it'll be your question we'll ask, but we won't be asking it specifically about you. We will make every attempt to address everybody's questions, housekeeping questions. Christy and I will take care of as we go on along, and we'll leave the clinical questions for Dr. Nguyen. You do need to stay through the entire presentation, but when Q&A starts, you're free to leave. As always, that's when a lot of the good information gets shared. At this point, I'm going to turn it over to Christy Handley with Sussex County Health Coalition for the next part of the presentation. Christy.
Great, thanks, Tim. Most of you know who I am and what Sussex County Health Coalition is all about, but for those of you who may not know, really quickly, we are an organization, a health coalition that engages our communities to ensure that their voices are heard and that we can fill some gaps in maybe some of the services that need to be made in our communities. And we support all of them through some collaborative efforts with our partners to improve all of our communities. And we evaluate all that we do to make sure that we're making an impact. Next slide. So this evening, we'd like to welcome Dr. Kaylie Nguyen. Kaylie earned her dual undergraduate degrees in biochemistry and molecular biology from the University of Maryland, Baltimore County. She received her Doctor of Dental Surgery from the University of Maryland School of Dentistry. And most recently, she completed her specialty training in periodontics at the University of Maryland in 2025. Dr. Nguyen is proficient in all aspects of periodontics and implant dentistry, and especially committed to important relationship between oral health and overall well-being. Her clinical approach blends evidence-based care with genuine compassion, helping patients achieve lasting oral health and confident, healthy smiles. When she's not in the clinic, Dr. Nguyen enjoys cooking and exploring new cuisines, traveling and making meaningful memories with her family and friends. Welcome, Dr. Nguyen.
Hello, everyone. I am Dr. Kaylie Nguyen, just like Christy just mentioned earlier. Welcome, everyone. Also, today I will get more into what I specialize in dentistry. Probably some of you know what periodontology is, and some might not, so let's get into it today. I am going to go ahead and share my screen. So give me a second.
Perfect.
Got it. Are you able to see the cursor?
Yes, we are.
Perfect. Let me zoom this out. So I am Dr. Kaylie Nguyen, just like Christy mentioned. I am a sorry, it's not moving forward. Got it. I am a periodontist who specializes in gum and implant specialist. What I do a lot every day is take care of everything underneath your gum, including your gum and your bone. So, what is periodontist? We are one of out of many dental specialties. So we have orthodontists, pediatric dentists, oral-pathologists, dental public health, dental anesthesiologist and prosthodontist, oral surgeon, and we are one of those as well. Um, like Christy mentioned earlier, I did finish dental school back in 2022. Then after that, I got in para-residency right away at the same school. So after finished dental school at Maryland, I joined para-residency at Maryland as well. After that, I moved to Delaware and started my job here in Delaware. Currently, I am at two different locations, one in Wilmington and one in Dover. And then on a weekend, I actually have a different job that I only work on a weekend in Maryland, where most of my families are. So I tend to travel back and forth. I know a lot of you guys here probably have some of these things that I'm going to list. If you have any cavity and you have ever have wear braces before, finished braces already, or have ever have a cleaning or no visit a dentist, dentistry is part of everyone's life where you do need your teeth to function, also for aesthetic as well, for long-term longevity. And what did this profession in dentistry mean to everyone as well as me? It is a healthcare profession that focuses in teeth, gum, and oral health. And I'm going to talk more about gum and oral health today. We treat and diagnose a lot of oral disease, including gum disease, cavity type disease as well. We also identify a lot of oral lesions, so in terms of like ulcer, any pemphigus, pemphigoid, anything could affect your functionally, including your oral mucosa, your gum as well, your tongue. Our goal is to be able to help patients eat, speak, and smile confidently, make sure they have a good quality of life, or improve their quality of life. Um, what we do is we also trying to prevent the problem before getting started. For example, you go see dentist every 6 months, trying to get your cleaning, get your periodic oral exam, your X-ray, just to make sure we are preventing problem getting worse or preventing something to start, including you will take x-ray just to be sure if you have small cavity or bigger cavity, or when you're starting to lose bone on some of the teeth, at what extent is it mild, moderate to severe. Um, Getting to what dental team is and getting to my profession as well or my specialty. Everyone see or everyone have a home care general dentist where they obtain their routine home care. And then that team will consist of a dental hygienist. They do your cleaning, your x-ray, examine you, and then the general dentist will do your exam. The team will always have an assistant where they help turn the room over, help talk to you, getting your medical history, and to actually make sure your procedure or your experience always flow in a positive way. And then in case of you need something else or something that the general dentist is not able to handle, they refer to a specialist who have advanced training in specific area. So like I said earlier, my training is focusing in gum and anything below the gum. So your bone, your gum, and your root. Um, to get back into why we really focusing in it, as well as what my career is really focusing on, what I base off how I treat all my patient, what I actually look at every time, not the finance part, not the satisfaction. It is have to be the relationship between you and your patient and your belief and what you can do to make it better. Your mouth does connect to your whole body. It is one of the opening in your body. So if anything wrong with your mouth, it can link to other part of your body as well. There are other part of there's other systemic condition that happens research for years and have been proven that gum disease, linguic, heart disease as well, diabetic, where patients who have uncontrolled diabetic, either type 1 or type 2 or type 1.5, with improvement of their gum condition, they can also improve the HbA1c and vice versa. And as well, a patient who have heart disease, who where the buildup of plaque around their artery can also found to be the same amount of the same bacteria that responsible for gum disease as well. How to smile does improve your confidence. It to make you smile if you do have a bad smile. A lot of patients have told me I don't want to smile. One of the chief complaint I got the most from patient are, "What your chief complaint? Like, why are you here?" They would say, "I don't like my style, smile. Can you make it up better? What can I do to make it better?" It will boost your confidence as well as your quality of life a lot. So overall, good oral health will improve your quality of life overall. This is actually, I wanted to put this here. Before I finished residency, I was working, moonlighting, at a general dentist weekend, for my resident as a general dentist. So I want to put this out there, but this is normally a day of a general dentist. And later I want to put you what a day of a periodontist, where you can have a hand-to-hand comparison of what we do. Normally we go in, so same patient, check schedule, make sure everything is prepared. So instrumentation, material, treatment room, how to plan out your day. Every patient, we have to review every single patient medical history or concern as well as chief complaint. We want to look at whether the patient is ready to get dental treatment or what is wrong. Um, like I said earlier, dental care does relate it to your overall health. So you want to make sure everything is reviewed. And then for patients who come for exam, we do a lot of examination as well, diagnosis, including oral exam. Every patient who come through the door will have a routine oral cancer screening, update the patient X-ray, see anything change, compare with previous X-ray, any cavity, any clinical exam. Then after that, we treatment plan whether is the patient okay staying at a recall schedule that they normally have, or they develop new cavity, or is the patient still interested in replacing whatever they've been missing in their mouth, or something is on, or if the cavity is too big, what is the next step? Is it need to be crown, or does it need to be root canal? What's next? Then in the schedule where we will always be some kind of dental procedure performed, where general dentist does a lot of fillings, crown, root canal, and extraction. A lot of them now are doing implant, and ortho, where Invisalign as well as they are trained for it. A lot of general dentists does obtain a lot of extensive CE in order to gain their procedure basis that they do at home, and that's our something they can add into their daily as well. On top of that, a lot of dental office, not only they have the doctor, they only have the hygienist. So the hygienist does do a lot of cleaning, and the doctor will come and check the patient for routine basis. So they check hygiene, for hygiene check, how patient to clean their teeth at home, or tell them any advice, any other treatment plan they have. One of the biggest thing we do in our career is, as well as our job every day, is patient education. Patient only see dentists one every 6 months, one every 4 months, one every 3 months. They are at home brushing their teeth every single day. They're not coming to us every single day to brush their teeth. So it's important for us to educate the patient how to actually brush and floss daily, how to actually brush and floss correct every day, to prevent problem from happening. And after every procedure, we always sometimes give a lot of post-operative, make sure patient follow their post-op. They do what they're supposed to do, why to ensure they are properly healed. After we see every single patient, we have to document what they told the patient, what our exam consists of, and what we've seen from our exam. This is what we call a treatment note every single day. We do those for every patient, just in case the patient call back, they have question, or the team member can address their concern, as well as if we have to send to specialists, they will need this kind of information, so we can base on this record, and send those to them as well. It's also a good, it's also used for legal purposes as well. At the end of the day, we review all the case, make sure there are cases that need to be sent to the lab. There are cases that we have to call the patient, update here and there, make sure the next day is okay prior to us going home. And we normally make sure that our no are finished before we get home. Um, this is a lifestyle as a dentist of what I personally have it for. While I look at it, it doesn't apply to everyone. This is what I've seen, and I put this up more from what I had as well as my colleagues, my friend along my age have shared. Majority of us are working in a dental clinic, either an associate or they are a private owner. Um, Almost all of them does teamwork, a hygienist and many assistant as well as front desk, treatment plan coordinators. So you do work with a lot of people in our field. We don't be in the office by ourselves. And just like earlier, the daily responsibility, including exam, diagnosis, cleaning, provide treatment and procedure to the patient. The work schedule does base off vary per person. I personally currently right now working 4.5 days a week. Some do work 3.5 days, some three, some four. You do have a lot of control of your schedule. Just so you know, just in case we do, a majority of us do not work off a salary base. We on collection base, so we does collect what we make based on procedure we perform on patient. Some clinic does have a salary base where if you work in a community clinic or it's based on your contract. But our work schedule, we mainly take control of it more, where we decide on how much we're working per our contract that we discuss. Um, every single day we go to work and we build interaction as well, relationship with the patient and other colleague. So we want to make sure whenever we see patient is not that patient we'll jump office every single appointment they come. We want to establish a long-term relationship with our patient. So sometimes you do see, for example, you see a family, kid, parents, and then later the kid go from like kid to teenager to adult. You keep seeing them. You build a relationship with the entire family, and that's something I'm very grateful for. We do attend a lot of continuing education. It is part of us to renew our license as well as how we stay on top of the current technology as well as the current education, what the technique is out there, what they have found, how to improve ourselves. So we learn a lot of new technology. So like whatever new implant system is out on the market, whatever kit they have, what technique they have out there, we wanted to learn so we could improve ourselves. Some of us travel a lot to attend some courses to extend on what we do. So, for example, if you're a general dentist and you want to do more implant, then you take more implant course and you become more comfortable doing it. And then, or general dentists who wanted to do more ortho, then you learn ortho course, or general dentists who want to do more advanced endodontist procedure like root canal that on tooth that have more root or like root that's curved, then you take this course to learn your skill, to learn something new skill as well, improve your current skill. Like I said earlier, we do have pretty much flexible schedule as well, good work-life balance. I've been in this field for 4 years now. I do have very good work-life balance. My weekend, I don't bring work home. Sometimes I have to stay on call for emergency cases, but I do enjoy my weekend work. I don't have to worry about much. This field does have good income. However, probably you also have known it is expensive to go to dental school as well, residency as well. So think and balance off. And then the characteristics of this position, this profession, overall dentistry, not just from a periodontology standpoint, you do need very precise work. The teeth is very small. Um, Whatever inside the tooth, for example, a fillings or a root canal, or whenever we do something, we are in the mouth where we are exposed to a lot of vital structure. We want to make sure our work are precise so we don't mess up. We make sure our patient health, overall health is our top priority. Precise work also means you have to document everything you do. Um, so in case you have to send patient somewhere else or you have someone to talk to you about something, you do have something to base off and talk to them accurately as well. When patients feel nervous, you also want to make sure you know how to manage them. A lot of patients I've seen have white coat syndrome. As long as you have doctor in front of your name, they are nervous. They scared to you. Um, and that's why some of them develop oral problem as well because they afraid to see dentists. You don't want to scare them away. Um, I did have a very long training in order for me to get into dental school. I had to have a bachelor degree where I did have to spend 4 years in undergrad. Make sure you get all your prereq course in. With a bachelor, you still apply to dental school. Um, you can get in, you get in. One year in dental school is say 4 years. I know some school in the country does offer a bridge program where I think it's a shorter undergrad and the same length at dental school. So you do can cut like 1 or 2 year down. However, these programs are very competitive. And then after your long training, you obtain your license and practice as a dentist. If you want to do more training like I did, then join specialty. It is still a lot of them are currently you have to apply and you get picked out of it. Specialty is a very competitive program, but I can get into it for you later down this PowerPoint. The next thing would be you also need to learn new technology. You don't want to stay behind. All material, everything out there, instrumentation, they all develop new things every day. You also want to explore to also help you be more productive, help patient feel better in the chair, as well as either it shorten your procedure length. You might want to explore that so you can see more patient, or at least shorten the time so patient don't have a long procedure so like before anymore. What I personally love about dentistry, and this come from me, I think this might um, work with a lot of other colleagues as well. I love helping people. I do volunteer a lot outside of what I do ever since I was an undergrad. Still love making something people make happy, restore healthy smile, help patient, seeing patient happy, walking out with something is accomplished is something that make me feel better about my career, better about my day. Overall improve patient health, like I said earlier, not just their health, but overall health, because oral health does link with other part of your body. Protect and prevent problems from happening. I love working with my hand. I have a very small hand to begin with, so I want to take advantage of it. Um, I do like detail work where it does challenge myself every day, but that give me a very reward career and at the end of the day anyway. Um, I do hand-on work every single day, almost every single my patient need hand-on. I do see my patient, even proposal, I have to see them myself. I love technology. We do a lot of X-ray, 3D scan. That's what we call CBCT. Majority of the X-ray you normally see when dentists do your cavities, these are 2D X-ray. As a perio, I do a lot of 3D because I do place a lot of implant as well as have to handle all the vital structure within your jaw. So I need to make sure most of my patient, and when I perform the procedure, I will do is 3D X-ray. Um, I love technology where we no longer take regular impression. I do a lot of scanning. First to plan my implant, second patient be a lot more comfortable on my chair. And that's what I prefer. And then I also want to give the patient the best care they can. Um, every single day of my day is very different. I have never done something the same. The reason is every patient mouth is very different. Everyone have their own unique treatment plan, even with a tooth extraction thing is different. Every teeth is different in the mouth, where the length of the root, if it curve or not, how many root per tooth is very different per case. Even though the type procedure can be the same, but via different patient, is they all different. Um, Even I do gum doesn't mean I do the same thing every day. Different case, different challenges, not even from a mouth standpoint. It's also how to handle each patient differently for them to be comfortable. And it's always learning new things for myself. How to become a dentist, as I said earlier as well. Finish high school, make sure you have some kind of science background or kind of light science in general, because this is gonna be the rest of your life if you're gonna get into this. You don't want to pay out this time, money, and then I'll put in dental school later because you realize I don't like this. So you want to make sure you're exposed to this beforehand. In college, you have to make sure you take all your prereq. You will take a dental exam test called dental admission test. This I believe is a 4 6 hour exam and it pay off a score. All dental school application need to have this score. So they look at you, rank you, compare you to different applicant as well. You also want to see dentists in real life, where if you see dentists and as a patient standpoint, is very different from seeing a dentist with a patient interaction. You want to make sure you always shadow dentists. Um, at most of my general dentist, just to get an idea of what being a dentist mean. See if you like it. If you hate talking to people, if you hate explaining things, this might not be a career for you. So you want to make sure you actually learn about it first. I did shadow three different dentists. I did work at dental assistant before I started dental school, just for me to make sure I'm in the right place. Dental school is very expensive that you don't wanna go in and then you end up realize you don't like the way it is. And it's gonna be a waste of money. A lot of things can go to waste and you don't want that. Then dental school is typically 4 years. You do get a DDS or a DMD. DDS stand for um dental surgery, and then the other one is medicine related, but they both very similar. We both equally the same. I actually had DDS because Maryland is a DDS program. And after that, if you want to specialize in one thing, instead of doing a lot of procedure, the type of um, specialties on out there that I told you, some of them are 2 years, some are 3 years, some are 4, and some are 6. Oral surgery are mostly 4 or 6 year. If you decide to be a 6 year, you do get a dual MD, like a medical doctor, as well as DDS or DMD at the same title. Majority of the perio program are 3 years. There are currently only one perio program in the United States, or 2 years, which is, I believe, are the one in New York City. Most of also the perio program here also require you to have a master along with your periodontal degree. So I actually have a Master of Science after my DDS. So I finished DDS, obtaining my perio with a 3 year perio certificate, as well as a Master of Science certificate as well. So I do have, after my name is Kaylie Nguyen, DDS MS. And then some ortho program or some pediatric program are 2 years, some are 3 year, depending on which one you pick, as well which one you apply to. Make sure you all learn about this more prior to applying, because some of them do take a good chunk out of your life. That being said, I did spend um 11 years in school since I finished high school. If you could guess any of the instrument and what they do, a lot of you have probably been to a dentist before, have heard other dentists within the same series have introduced you to these careers. You know what they are. Some of the first one we have here is a mirror. Every dentist needs a mirror on their tray. I personally have my tray have two mirror. It's very different depending on how your reference is. Each of the mirror also come in different sizes. As well, we use to look indirectly to some of the back teeth that you can't see directly with your own eye. So you use what we call indirect vision. As well, you use this mirror to actually retract in the patient mouth. So in the patient mouth, there are cheek, tongue, lips. You want to retract some of these out so you can see it more, particularly in the back teeth. And the second thing is what we call a explorer. These are what we use a lot of general dentists use to detect cavity, see any irregularity that they notice. The next thing is a scaler. The third one on this list is a scalers. This is actually used to scale calculus off a tooth, or if they want to smooth out something, scale some overhang out, they can use that as well. So what calculus mean is if you have tartar stay on your teeth and you don't clean it, after 48 hours, they become hard. When they become hard, when you brush it, they don't go away anymore. So the longer you accumulate them, they become harder and harder. They say are food trap bacteria, bacteria product all in there. And you go in, and when you go to dentist, we do need scalers. And what your hygienist will need a scaler to remove some of these. And then the last thing is a handpiece. These are a rotary tool. So this can use for a lot of procedures. So a lot of general dentists use to drill out your cavity before they can pack them. Some use to section the tooth so that you can easily remove each root and make sure each root come out atraumatically. In endo, they use this ones to use the rotary instrument for the endodontic treatment in order for them to clean out the root canal. In periodontology, we use this to smooth out bone, any irregularity when we see during surgery. We also use this to place implant, so we can need some kind of tool with a high speed that can give us water as well to reduce heat to draw out the bone in order to place an implant. I will get into implant as well as gum surgery later on. Then, like I said earlier, what orthodontists do, they straight teeth. Pediatric dentist is kid dentistry. How to manage kid as well is one of the biggest thing. You also, it's harder to manage kid compared to adult. And prosthodontist is they do a lot of teeth replacement in complex case. So when patients who have lost teeth for a very long time or depend on their bite, if it beyond the capacity of a general dentist do, you do want to make sure you refer it out to a process where they can handle this case a lot better. I do work with a lot of general dentists as well, prosthodontists to help navigate some of these cases to work together because I do a lot of surgery, places implant for some of these patients. Between also surgeon as and a periodontist, we do overlap a few things. So oral surgeon do a lot of jaw surgery, wisdom teeth removal. They do jaw reconstruction. They do a lot of implant. They do a lot of sinus stuff as well. Periodontist, we do very similar thing as well. We do overlap, including place implant. We do sinus lift. If there's case that doing the same thing, but for patients who are a little bit medically complex that need to be sedated or more risks happen, we do tend to refer to an oral surgeon where if their facility is able to manage this patient, we do refer out because majority of periodontists do work in a private practice, so some may not have full capacity to manage some of these complex case. And then an endodontist who do root canal do a lot of root amputation. They have very, I admire endodontists a lot because they look at teeth very differently than how I look at it. What a periodontist is, we do specialize in gum as well as the bone supporting the teeth. Without bone, there's nothing gonna hold the teeth in place, and teeth eventually will fall out. Without cavity, without teeth fracture, these teeth will eventually fall out if there's no bone. They still require an extra 3-year training after dental school. So around our third year of dental school, finishing third year of dental school, starting that May, there will be an application you're gonna start working on if you decide to specialty, specializing, and that application will give you rec letters, where to apply, how to prove you have this and that. They will need some kind of recommendation letter from like who worked with you the most, why you think you are a good candidate for this um, career or this specialty, and make sure you show a lot of interest in it. Then after that, around August of your 4 years, that what I went through as well. There will be a lot of in-person interviews. So I personally have in-person interview for my perio program, um, where you do meet and get to learn the program you want to spend the next 3 years, which you want to look at what technology they have, what they focus on, what criteria out there that fit you the best, as well as the location you want to move to. Then after that, I did went through a match process where you enter your rank of where you want to go, number one, two, three, and then the school also rank you who they want to take in. And if where you like is the same place at the program director of that person do like you, then you both rank high and you probably end up matching. And that's how I found out. So I did found out I got in residency November of my 4 year of dental school. And then luckily I was able to get in Maryland. So I didn't have to move and I stay in the same place. I already know the school, I already know the staff, I already know everyone there. So I was very lucky about that. I personally, when I applied, did not want to move somewhere for, so my goal was I only applied to school within 2 hour distance from Maryland, so I only have VCU, which is Virginia Commonwealth, Temple, Maryland, as well as Penn, and then I end up got in Maryland. Um, Earlier I've been talking about lateral gum disease, what they are. The terminology of this is periodontitis. It's a serious gum disease that does affect the tissue and the bone around your teeth. These are caused by buildup plaque, which is a biofilm related, which is bacteria. They form tartar, unable to remove. They reach below your gum line, leading you to have some kind of gum infection. One infection there for so long, leading you to have gum irritation, inflammation, bleeding. So you start with gingivitis, if you leave untreated, you do have end up with deeper gum pocket, as well as more tissue damage. Not only tissue damage, including both soft and hard, so you both will damage your gum as well as the bone underneath that support to hold your teeth together in your jaw. Some of the symptoms include red swollen gum, bleeding, receding gum, most noticeable bad breath. And whenever you floss, you brush, you're probably gonna notice your gum starting to bleed. It doesn't mean um, flossing causes bleeding. It means something is currently going wrong with your gum, that when you floss, it's leading you to have bleeding. And then eventually, when the bones around you starting to lose a lot, your teeth become loosened. The biggest risk factor would be poor oral hygiene. Smoking is a huge risk factor for gum disease. A lot of patients who smoke long-term smoking, depending on how much they smoke, they will end up with some kind of bone loss, whether it's mild, moderate. A lot of the patients I've seen here in Delaware, as well as when I was in residency in Baltimore, a lot of my patients smoke, and almost every single one of them have a different degrees of bone loss around their teeth. And then, like I said earlier, diabetes is a huge thing for bone loss as well. Um, and genetic can plays a role. So we sometimes we do see a lot of teenagers already starting to have the bone loss, and some medication can induce more bone loss as well as how you recover from gum disease as well. How to treat gum disease. Um, Want to be clear now. Being a periodontist is hard. Where a lot of patients think they come to us, they lose bone, we give them back their bone. I'm not a magician. Um, Our goal is to clear tell patient every single time they see me as well. I can't give back your bone that you lost for the past 20 years. My goal is just make sure I can stop your bone loss, prevent it from getting worse, or at least lower the rate of your bone loss currently. That's how I look at it. We perform a lot of professional cleaning, deep cleaning, sometimes do a lot of combination of both debridement as well as medication. And then in some cases, after some of these medication as well as deep cleaning, we do see patient again re-eval whether do they need gum surgery or not. The word surgery might sound scary, but it's pretty much very minimally invasive. We do with some kind of patient with a lot of bone loss or deeper pocket, we have to actually have to open up the gum where I see everything with my naked eye to be able to adequately clean everything underneath, and then we put back the gum together. The only thing the patient come out after any surgery is you just come home with stitches. That should be the only thing different. As well as a cleaner mouth. In order to prevent, make sure you always have your routine checkup, what we call recall checkup, X-ray, very good oral hygiene at home, and I always advise patient make sure you stay up with your systemic health, because sometimes a patient go off the radar for even go to their primary care doctor. They can end up with uncontrolled diabetic or uncontrolled hypertension, uncontrolled any cardiovascular condition that could negatively affect your gum health as well. And most importantly, quit smoking or don't smoke. That would be the biggest thing, because treating patients who smoke, everything we do can become very unpredictable, even with implant, with gum surgery, even with anything we do. Um, Smoking can make nothing work or make things worse very fast. When you look at gum disease, there are different stages where you look at healthy gum, meaning the gum look pink, firm, you don't have bone loss. How do we determine whether you have bone loss or not? We do both clinical exam where we probe your pocket as well as check the bone level on your x-ray. So your routine x-ray, your bite wing as well, your PA will show us where the bone level is. And then when you start forming plaque around the tooth, like this, these are bacteria your gum hate it. Just imagine if you touch something dirty with a cut, things starting to inflame, no one like it. So your gum starting to inflamed gum, red swollen gum, and then if you have bleeding gum or something swollen, you touch it, it's going to bleed. So of course, whenever you brush or floss, it's going to bleed. Then one, the total getting hard, which I called earlier, um, calculus, you're starting to develop some kind of periodontitis, whether it's mild, moderate, or severe. You will notice on your x-ray, you're starting to lose bone. When you start having bone loss, that's when you have periodontitis. So your gum starting to recede. Thing is, you do need bone to provide blood supply for your gum. If there's no bone, there's no gum. And then in kind term of advanced periodontitis, where you have extreme pocket, your teeth become so mobile, severe bone loss. In some of these cases, we have to extract the teeth out, and that's when we have to consider tooth replacement. Then most of the procedure I perform, as well as what I share a lot with my hygienist, is scale root planning. This is a scaling root planning. Scaling means we scale all the tartar. Root planning, we keep the root clean. Because there's bone loss, the root being exposed, so we have to do that. The regular term, the usual term is deep cleaning. I do also a lot of gum graft for recession. I will get that into that with a case later, so you know what I talk about. And I do a lot of bone grafting for patients who lost bone or go through either traumatic extraction or bone loss prior to you losing a teeth. You do want a bone graft in order for you open you to more treatment in the future. So including dental implant placement. Dental implant need to be fully in bone. So patients who have bone loss, we tend to graft bone just to make sure your implant will be completely in bone. You don't want to place the implant halfway in bone, halfway float in the air, then that way it doesn't work. I do a lot of regenerative procedure, including bone graft as well as vertical bone defects in gum disease patient as well, but very selectively for patient is more predictable result than when I perform that. Looking at the technology of what I do with every day, we take a lot of x-ray just so I could see where the bone level is. Not every patient I can open the gum up and see where the bone is. Ideally, if I wish I could open everyone up, I would, but no. Answer is no. So the baseline of care for me to see where the bone level is would be your x-ray, multiple angles. So that's why we do a lot of PA, where I see how long the root is, where the bone currently is, and a lot of bite wing, which is where I see the actual crown and the bone level. 3D x-ray, 3D CBCT scan. Like I said earlier, this will be more if I have to do any advanced procedure like bone graft, implant, sinus lift. I need to know where the vital structure, including on your jaw, there is a nerve, inferior alveolar nerve run right here, which will supply the sensation for your teeth, your lips, down here. If you are placing implant down here, you always have to put that into consideration. You don't want to impinge the nerve. That way, patient will end up with paresthesia. So you make sure you always have these 3D scan as standard of care. When it comes to that, when we do a sinus lift, we also make sure where the artery is, the PSA artery. So when we perform the sinus lift, we don't end up puncturing it, leading you to patient have excessive bleeding. There's also structure in the lower jaw, upper jaw as well, and you want to make sure you avoid all of that, including your salivary gland, your artery. You don't want to deal with that. Scanner, we no longer taking, or majority of the office I know, no longer taking any physical impression, unless there's case by case, but majority of us do just scan, so we know the patient bite. We can study after the patient left, just to know how to plan our case. And then in gum disease, we do a lot of laser for gum treatment. This is a little bit more advanced. in order to treat gum disease for patients who are a little bit nervous, who they don't want surgery at all, but it's all dependent on our call whether we're going to do traditional gum surgery versus laser gum treatment. Not everyone can qualify for this. And then we also do a lot of guided implant surgery that will need both digital scan and the CBCT for us to plan exactly where to place the implant, the size of the implant first. It gives us a very much accuracy of where we place the implant to actually avoid all the vital structure as well. The implant can be restorable. What is dental implant? Finally getting into it because I mentioned this word for a while. Majority of you are pretty young. I don't think you have any implant in your mouth yet. Probably some kind of your family members or relative might have one or two implant in their mouth. It is actually a titanium screw that plays into your jaw bone. You only want to place this in bone. You don't want to place it in gum. What it does is when the titanium screw is placed in your mouth, your jawbone, it will take time to heal, and your jawbone will slowly fuse again to hold this implant in place. Implant is used currently right now to replace a lot of missing teeth. So patients who have missing teeth, instead of going with the other option, for example, a bridge or a partial denture, patient can opt in for implant treatment as well. And then sometimes we do place mini implant or implant in the jaw to actually pull a tooth down. So some of you might have heard, or I'm not sure if other orthodontists around here does it, but you can place implant into different part of your um, jawbone and starting pulling some of the impacted tooth down. So some of you might know like impacted canine, impacted um, lateral incisor, they can use that to use the force to pull down some of the teeth. It is very advanced dentistry. It's advanced, but it's not old. No, it's not new. It's been here for the past 30, 40 years and very well known in the market. If you Google implant, you know exactly what it is. Um, what's my life? What a day of my life at a periodontist is. Like I explained earlier, I did went over what it is for a general dentist because I did practice that 3 years, and after that, for the past 7 to 8 months, I've been a periodontist. So this is what my day every day is. A lot of patient exam. I do a lot of new patient exam. A lot of my patients are actually come referral based. So patients don't just walk into my office and ask to see me. I mainly see patient, probably 95% of my patient are referral based. So I only see patients who actually have an established general dentist and they refer to me because they needed my help. I see them. I mainly take care of their gum and their bone. I don't do filling, I don't do crown, I don't do root canal. That being said, I want someone else to take care of it and make sure everything else is okay. And what I can focusing in the patient gum. Sometimes I do see patients that have some cavity. I will inform the general dentist, yes, I see this and that and that. So a lot of communication between me and the actual dentist who refer the patient here. I check them how I do oral cancer screening. We do see a lot of pathologists, pathology lesion within our office. The gum and the bone are where a lot of you see a lot of overgrowth thing can happen, or any cyst lesion that within your bone and your jaw to take place. So I see a lot of that. And then every patient walk in my room per referral mainly come for comprehensive perio exam. So I check all the gum health in their mouth, every single teeth. Each teeth have 6 different sites. So I check every single one of them. First, it give me an idea of how healthy gum, how's the health of the patient's gum is. Second, I could see the bigger pictures. What the problem is, I look at how much gum they have left, how many recessions they have as well. Then I take a look at a lot of X-ray. My career, as well as a lot of dentists, is based on X-ray as well. So when I look at a lot of CT scan where I can plan my implant, look at how the bone loss is, how I can treatment plan, can order the right supply. So I look at all of X-ray so I know where to place the implant, what size the implant I can place. Then I can order the right things, or if I need any special thing for this case, I can go ahead and order it prior to the patient coming in. So when they come in, I have everything on hand. Treating gum disease, we do a lot of e-cleaning, scan root planning, Our goal is to reduce the amount of bacteria in your mouth so that your overall health can be better. So I do reduce a lot of gum infection, improve overall gum health. I place a lot of implant. So general dentists do place a lot of implant. It's more a little advanced case or a little difficult case. They do send over to us, as well as the oral surgeon, and we do place those. So some of my implant will include bone graft at time implant placement or bone graft prior to implant placement, or patients who have severe bone loss came to me with no bone, then I have to make sure I gain bone prior to me placing implant, or case that related to sinus lift, where sinus is you have two maxillary sinus up here on your upper right next to your nose. You don't want to have the implant halfway in your sinus, halfway in your bone. That way, thing is not going to go well. So you make sure we do procedure called a sinus lift to make sure you are okay prior to us placing your implant. On top of that, I do a lot of gum graft surgery. This is when I see a little bit younger patient who have a lot of receding gum. First, it could be from they were born with very thin gum, so they are more prone at having recession. Um, and then a lot of them is after ortho. They did have, because of the teeth move in and out for a little bit. So they end up with thin gum and recession, which again, they come back. And some of them can be because of trauma. We do gum receding, so that improve the root coverage of some of these areas as well, just to make sure it lasts long, so that their gum can be thickened, prevent further recession, or in some case we do gain the rest of the coverage for the root that has been lost. Oh, this is some of our cases, my cases that I've seen in private practice. Some belong to residency. This is actually a patient that was sent to me because he had recession on the tooth here. If you notice, compared to other site, he is a male. He did went through a little bit procedure as well as jaw surgery at young age because he did not have some of his teeth growing up. So like he have congenital missing teeth. So this right here is an implant, and then they should end up with a lot of recession. They were a little concerned because when you have recession, sometimes it's harder to brush or clean in some of these areas. You notice his gum is a little bit red here. So we do a procedure called connective tissue graft. So in this case, we actually harvest the gum from the root of the patient's mouth, and then we transform it here. We leave the root open. This will fill by itself after 7 days or so. And then this one will allow between 2 to 4 weeks to completely getting this result. This, I believe, was a 6-week post-op. We did gain a lot of root for this patient. And now you see the same level here and here. Don't worry about the color. It is the discoloration of the tooth itself. But you did notice from here to here with your gum a lot thicker. So to prevent him getting worse recession in the future or recession in the same area in the future, not only we did gain the thickness of the tooth here, we also did gain the thickness of this one as well. Just we're gonna prevent the recession for this one in the future. Um, and then this is one of the residency case I did have. This is probably, I didn't do the surgery for this one, but I did have to follow up the patient because the resident who did the case actually graduate. This is him before. I swear this is actually the same person. This is probably one of my best patients on earth that I have treated so far. Very, very nice man. He did came with some teeth are broke, severe thing from his previous smoking habit. Thing wasn't looking good. He hate his smile, he hate his life. He doesn't shave. He lived like a man cave. That's how he told me when I first met him. And then for him, we actually did a few things. I didn't want to put all the X-ray up here because it might scare you. But what he has is we actually have his entire mouth extracted. Because I have a lot of bone loss, we actually they decided to do implant over denture for him for the lower, where in a lot of patients where they lost a lot of bone for a very long time, when you put the denture in the patient mouth, it doesn't stay. It keep moving every time you speak, you talk, the denture keep moving back and forth. So what they develop is they actually develop what we call an overdenture when they place implant into the patient jaw, and then they use a button snap. So it's basically this patient have 4 implants for the bottom, and then this denture snap in like a button. So every time he want to wear it, he snap it on. And then every night before he go to bed, he take it off. So that way he can clean everything else up there. And then on his top, he actually have 4 implant plates. And what he have is actually an upper hybrid. This is an all-on 4 implant prosthesis, where this is actually a prosthesis that hold by implant. We don't take this out at all. So the top one glue in with 4 implant, and the bottom taken in and out with implant. So these two are two different things. Is you implant to help you hold the teeth, but they are two different things. So one of them is removable option, one of them is fixed option. The biggest thing is how much bone the patient have, how the patient bite is, how we determine what patient treatment we can offer, as well as the finance of the patient, what they can afford, and then we give it the patient pick and choose what they want to do. But this is a transforming experience for the patient. It did cost him a lot of money, but he actually very happy at the end of the day. I personally did not take this case initially with someone else did the case, and then I would managing the patient through recall, make sure everything is healthy through the years. And even though I didn't do surgery on this patient, but he probably one of my best patients that I was very happy seeing him from start to finish. Um, This is very unique, and I don't think you guys kind of experienced this earlier. I didn't get into this much at all. Um, this is actually a little girl. I think she was 12. Um, she has some impacted tooth, and with her growing, her baby teeth still in place. So she's right here. This is her X-ray, which this is what we call a panorex. X-ray is capture your jawbone, a little bit your spine, a little bit your sinus here, your condyle, and all your teeth. We have canine here impacted, and then these baby teeth here. And then on the lower, you see this impacted canine as well. Canine, the cornerstone of teeth, is one of the teeth with the longest root in your mouth. You do want the teeth because it's some canine guidance as well as the guide how your jaw move left and right. So in this case, instead of going in and remove some of these impacted canine, we decided to move this canine down. So after we remove her baby teeth out, the two right here, um, patient went through ortho with other spacers here. We make space to pull the canine down, and then we, as a gum specialist, we actually invite you in this case. I work with this with an orthodontist. He did ask, "Can you bring some of these teeth out for me?" So I would open up the patient's gum, and then I would attach a bracket into each of the teeth from different perspectives. So one of them is here, one of them is here, and then one of them is right here. And then after, I believe this is a month after the procedure, this area is still a little bleedy. Just because the patient didn't keep it clean and ready for this photo, we did took the photo, and this X-ray was taken 4 weeks after we stopped pulling it down. You do notice this one is starting to come down completely. You could see it more on the pictures now. So that way we could bring the patient canine down. We did brought this canine up, and this one, it came from this location. So this location is still coming down. It should come a little slower. After that, I think this girl went back to ortho and continuing. She probably finished by now. But I haven't seen this case again. So that's why my pictures is here. Um, there's a lot of things out there on social media, what you seen, um, and there's a lot of myth and fact um, about our career, what they do. I'm here to tell you what I do every day. It might not apply to every dentist out there, but this is my true experience as a dentist and what I've seen so far through my colleague, my friend, what I went through residency and here. Dentistry is work the same job every single day? The answer is a no. We do a lot of procedure, we do a lot of things. Like I said earlier, I do a lot of different type of procedure. My day is never the same. Even most of patient within a day, I never do the same thing. Everything is different. Dentistry is very diverse. A lot of dentists they own their private practice. They run business. They do management on top of what they treat patient. They have to run staff. They have to do all these things. A lot of dentists still work in the hospital. Christiana Care does have a dental clinic, so dentists work there as well. University of Maryland have a very big dental clinic as well. Even John Hopkins have a dental clinic. So a lot of us can work in the hospital where we some dentists work in the hospital where they actually see a lot of patients who have extensive medical care that has to be in the hospital, but they need to have some kind of emergency treatment done or something done. So it's always available there in the hospital for them. A lot of us decide to teach in a university or at a residency or in the hospital. Teaching is a career in dentistry. Some people they retire from dentistry early after 10, 50 years, a lot of strain on their back, on their body. They decide to go teach. Or a lot of them start off, I love teaching, I love giving back, let me teach. So there's a career in dental school. You can teach students, you can teach a resident. So that's something there for you as well. We do research. I personally have an MS, so I did have to do research in order to get my resident certificate as well, my parent certificate. So I did have to do research. I did research since I was in dental school, so I did have a 7 year doing research with my background and everything. I did decide to stop personally myself because I wanted to focusing on something else. I wanted to step out of real life. I personally wanted to make sure that there's things that I'm missing, like that I want to focus in because I've been in school for so long. I want to get out there, go have fun, enjoy without worry much. So if there's something I have to give up, and I pick private practice life. I do volunteer around the world. So I haven't volunteered as a periodontist. Yes, I did a lot with when I was a GD, working at GD, where there's all a local clinic. I volunteer myself in majority host on the weekend, where I go in free treatment, free dental work for people who actually need. So I work with a lot of churches. I did a couple this past year in Virginia. I haven't done anything in Delaware yet. I did Virginia, Maryland. I did travel abroad to do my dental mission trip care for people. It does add up the cost, but it's give you if I already make this money, I do want to set a certain amount on the side to actually give back for people who actually in need. There's patients out there who fortunate to be able to obtain as well the cost of everything that I provide. However, there's people out there who truly need my help, and if my weekend is free, then I'm willing to go. Or 1 a week per year, I'm happy to travel to help out. Um, I do specialize. There's multiple specialists in the area. It's not about one thing. It's not that you do filling all day. You do crown all day. It's not like you do extraction all day. No, a lot of our specialty include it's more than what you think it is. Even with braces, there are multiple types. There are braces. There's surgical case. There's orthodontic case. There's Invisalign case. Not everything is the same. Even with root canal doctor, like the endodontist, they don't just do root canal. They do root canal, of course, but that's through multiple approach. They use endoscope. They use multiple type of instrument. They do a lot of apicoectomy where it's surgical root canal, and then every day look very differently from my end, as well as every dentist out there as well. Um, I explained earlier if you're gonna bleed, you should stop flossing. Answer is no. It says it's sign of inflammation or gingivitis. Healthy gum should not bleed. So I want to let you know that as well. Majority of my patients, oh, my gum bleed. I don't want to do it. I would ask patients, why not floss? My gum bleed. I can't do it. It's scary. You have to tell the patient why your gum bleed. Is it because of flossing or is it because of bacteria, plaque, and inflammation? And that's the thing. How to help? Flossing is the biggest thing. Brushing, regular dental visit. Make sure you catch something early before it get worse. Prevention is better than solving the problem. And then gum disease only happen to older patient. No, it is happen to every single age, even teenager. It can be a little bit less in percent of the population. However, because of genetic as well as what they expose, a lot of teenagers can have very much severe gum disease. Some of them related to poor brushing, flossing, genetic, smoking. a lot of us starting to smoke and vape at very young age. So I do see like early 20, early 30 years old patient with severe bone loss. And certain health condition does have you more prone to having bone loss as well. Dental implant or fake teeth that just sit on the gum. The answer is a no. Dental implant is a titanium root placed into your jaw. They put fake teeth. They need bone to stay in your jaw for it to function. If it's just sitting in the gum, every time you move and you bite down, the implant gonna move, so it's not functional at all. It does function like a teeth. However, if teeth have bone loss and gum disease, there's also implant disease. Doesn't mean you have implant, you're never gonna see a dentist again. That's a no-no. You do see the same routine with dentists and make sure thing can catch early. Because at the end of it, you don't want to lose your implant that you spend a lot of money on. Um, like I said just now, if all your teeth are replaced with implant, I no longer need to see dentists anymore. No, regular dentists and cleaning are very important. Implant doesn't get cavity. However, if you don't have cleanup, if you don't clean it up, you don't have routine, plaque tartar can build up, gum around the implant can become inflamed, reach your bone, you're gonna get bone loss around implant. This is what we call peri-implantitis. Eventually, if you're starting to lose bone around implant, you don't get to treat it, keep going, lose bone, the implant will fall out of your mouth. Um, Last slide. If you're ever interested in dentistry, make sure you start now. Focus on your science class. Make sure you are exposed. Start to volunteer, shadow dentist, or actually work in an assistant. You know what this field is about. You don't want to spend 11 year, 10 year, 8 year of your life doing something you know you hate the actual career of it in the future. So make sure you always expose the field beforehand. Reach out to local dentists, reach out to your family members, reach out to anywhere. They love having people come through. It depends on their day. If it's just a hectic day, they might not invite one you there, but just reach out. You can plan ahead. They love to have you around and prepare for a long training and expensive. While you're in training, it's very hard to work. I would manage to work only in residency on weekend twice a month because I do want to have a life, a lot of studying, a lot of patient exposure. You also want to have to make sure you prepare. So very long training, you will have to give up a few things in your life. So like you can't go on vacation. Could not go on vacation with my family for a very long time. And the moment I finished residency, I went for like 2 months. Um, and it's just prepare for it. You don't want to surprise yourself and or being in it halfway and end up quitting. Always ask questions, stay curious, be involved. We all love having you around. We do have my office in Maryland because it's your general dentist office. We did have a lot of patient kit that asks if they can come on weekend or they can come in off school, just at least shadow and see what's going on. We all will welcome them, and then they just stand on the side watching us. They're involved in conversation as well as treatment plan discussion with the patient. So this is the last slide I have for everyone. I know I've been talking a lot. I'm ready for your question or concern now. Anything you want me to clarify, or anything question you have at all. I'm here.
Okie dokie. We've got 4 questions right now. Thank you very much. That was fascinating. So, how do you see the specialty of periodontics evolving with the technological advances in the industry?
How I see perio with a technical.
With periodontics evolving with new
Oh.
technology and techniques?
It's dependent on how each perio want to evolve. So because I am pretty young in my career, um, and I like faster thing. I do like new things. So like I do a lot of CE. Whatever out there is better for the patient, I am happy to do so. However, there is things that I have to take consideration. So I don't just see things on the market and get into it right away. No, I have to make sure thing is actually have been studied, have been ADA approved, or at least through a lot of studies. So like systemic um, study paper. I read a lot of paper to make sure it's actually people out there have tested out first, and before I were to bring it in. And even when I bring it to patient, I want to make sure I test it out with one or two, inform the patient, let them know, and then I use that. Technology is out there. We do want to make it better, but again, we whatever we learn in school or what we call traditional surgery, parasurgery or traditional perio technique, these work. It's been approved for 100 years. It work. It still work now. But we also have to take consideration you want to take care of time. Patient do research a lot out there. They look at what is out in the market. They will come to you, be like, okay, I only want laser treatment. At that time, you also have to explain laser is out there. Is that benefit to all patients? The answer is no. It's very patient selective, so we have to make sure the patient know of that as well. But it's also dependent on whether the periodontist who in charge of who look at the case, whether they are willing to try all of this out or not, and how they look at different things is out there. But not every, like I said, not everything out there is proven or work. It's how you actually look at it yourself.
Okay. And how about one of the things we hear in orthopedics and plastic surgery is 3D tissue printing. Is that something that you're familiar with?
Um, so 3D tissue printing. So if you do like jaw, so for example, if you do like a jaw things, um, for like a jaw replacements, for example, if you have a patient who need a jaw replacement and you need kind of fake jaw, they do printing them or they do like make the jaw with the screw and everything in there. Yes, it is available in dentistry. So if you look at it in dentistry, a lot of patients have bone loss to severe. Some you have this much, some you barely have anything. So you want to gain as much thing a patient you have possible. So there are customized mesh membrane out there that for you to print to customize from the company. They will print it out, sterilized in titanium mesh. You go in, you put in a patient mouth, it fit right over the patient because it was designed to fit in that one particular patient. That way we know exactly how much bone we need to gain for the patient. Just so our future procedure going back in with the patient, we know exactly where to place the implant, how much bone we have gained from the previous bone graft procedure. So if you look at it that way, it does. We do have it here in Pero, whether if this doctor is willing to do it here or a patient is willing to pay this amount to get this procedure, it's always available for the patient if the doctor is willing to do it that way.
Okay. Um, how does working in different states or cities look like for a dentist? Is there significant regional difference for the practice of being a dentist?
Um, so let's just talk about me in Delaware now. I work in two different places, one in Dover and one in Wilmington. If you look at it this way, Wilmington a little bit more like the population we treated up in Wilmington are more of patients who work in corporate, a lot of teachers here and there. In Dover, where my other office is, I do treat a lot of older patient population. My patients tend to travel like 2, 3 hours to get where I am. So we do treat a different type of patient population. Our procedure offer is the same. It's mainly dependent on where I want to make sure for me, in order for me, I picked over because I want to make sure my patients have access to me because I know for me, being over, my patients still travel like from the beach. I did have patient who took a ferry to see me this week, so that was a surprise to me as well. But I want to make sure I put myself out there where the patient have access to my care, and that's what I enjoy. So I don't mind travel from Newark down into Dover to make sure my patient have access to my care, and I'm happy doing that way. The different within the same city is I still belong to the state of Delaware, so I use the same board or same license. But the reason I still practice in Maryland is because my family is there. My parents are there, so I come. It's give me a reason to go back and hang out with my friends, enjoy my weekend in Maryland with my family, and while I'm there, I can do something else. And because that office in Maryland, for me, I do have a Maryland license. Go through the whole thing to obtain my license thing. So I do have a Delaware and Maryland license hand in hand, both active and both in good standards. Go back to Maryland. That office, I've been with them as a GD. I grew up there. Um, and then it's just the community that I've been treating for so long. And I actually went to high school there as well. So that's why I decided to stay there, just because I know a lot of people there. And they know me too. But here, because I moved here recently, but I do want to make sure I put myself in like a rural area in Dover to let people have access again. That's why I did that.
Right. All righty. So I had to read this question a couple of times in my mind before I actually realized what it was asking. Are there specific types of chewing gum that are good for the teeth or that you would recommend as a dentist, as a periodontist?
Um, I have to be honest. I personally never a fan of chewing gum myself. The only patient who I actually recommend chewing gum would be there's chewing gum out there that are used for patient with dry mouth.
Mhm.
That will be the only time. I'm not a chewing gum person myself. Um, for myself, when I look at chewing gum, and it could be biased, I don't see much study out there that talk about what chewing gum is best for you, or something I haven't heard of. So I can't stand by anything. Is also when I look at it, it's more of like a pleasure, um, to make sure you do something, for your teeth. Is chewing gum good for your teeth? Some patients who love chewing gum and it gives them good breath here and there, but you're putting a lot of muscle in function all day long.
Right,
So overall,
right.
you are overwork some of these things in your mouth that can take some time to rest. Some of the patient have fake teeth, where they have a temporary crown and they love chewing gum and their temporary pop in and out every single other day. That what a lot of I've seen. They come as like, oh, why did your temp pop out? Oh, I just eat like Laffy Taffy or chewing gum, and then it happened. So to answer your question, I don't know much about chewing gum because of what I specialize into. I don't have it that much. But what I know of is I do recommend chewing gum for patient a particular type of a patient have dry mouth because of their medical condition, and that will be what I stand for. But do I
All
recommend?
righty.
I don't think I do.
Makes good sense. So in talking about in your Dover population with a the older part of your Dover population, we have a question here. If you have osteoporosis, should you get a different type of X-ray than just bite wings?
Um, mm, so in order for a doctor to diagnose your osteoporosis, um, you need a DEXA scan. That's prescribed by your medical doctor. It is to determine your bone density itself, and there's a range, that they look at after your DEXA scan to see if you have osteopenia or osteoporosis. And osteoporosis or osteopenia are a medical condition that need to be diagnosed by your um, medical doctor. I don't diagnose it, unfortunately. So if a patient who have osteoporosis, do they get different type of X-ray? The answer is a yes and a no, depending on what the patient need. So routine X-rays are bite wing. I personally, in order for me to provide a common exam, I do PA. So I need to see how much the root is. Some patient I do require a pan, but a pan and a bite wing do not tell whether the patient have osteopenia or osteoporosis. It is the DEXA scan with a medical diagnosis give that. But whether can you see if the osteoporosis get worse on the bite wing or the PA from this time point to this time point, the answer is a no, you can't. So hopefully that answered your question.
All righty. What are the factors that help you decide that you wanted to specifically work as a periodontist? And did you ever consider a different field in dentistry?
Um, I probably have to answer this question like 10 million times because they did ask me when I tried to get in perio. Um, when I was a dental student, as dental student, you got exposed to a lot of field. You have to do a lot of rotation during your third and fourth years of dental school. Um, I did not like being a general dentist myself because there's so many procedure. It's too broad for me. Um, And at the same time, I did a elimination test to see if I can see myself doing this every day per different specialty. So at that time point, I was like, do I want to do root canal all day? I did not want to. Do I want to do prof, crown, bridge, complicated case all day where patients who have like lost half their jaw and they need something? I can't do it. I personally could not see it myself. And then would I be okay with doing jaw surgery all day or be in the hospital, be in the OR for long 6, 8 hours with my personality as well as how I looking to live for my life in the future? I could not be an oral surgeon. Orthodontist was an option out there. Everyone told us be an ortho is great. Your life quality is great out there. To me, I could not see myself bending wire. That's how I see it back then. Now I look at it differently. But back then, 4 years ago, when I look at that way, I couldn't do it. So I was debating between Pete and Perio myself. And overall, I couldn't see someone crying. So then I wanted to challenge myself with Perio. I told myself, at least I want to give myself a shot. If I couldn't get in Perio, it is a very competitive um, specialty out there. There are actually currently only 40 program out there, and each of them only take 2 to 3 students per year. So overall, I was lucky enough to get in, and I decided to push through it.
Right. So, last question, I think. How much of your daily practice relies on the core sciences like biology or chemistry versus technical hand skills?
Um, Now that I'm like currently practicing more, I would say 99.9% of my job right now depend on my hand skill. But in order for me to perform the procedure, I need to understand the science behind it, and I have to believe in it because I can't just go in and open someone's up without having any background.
And
And I
we
didn't know
appreciate
how to
that.
manage. Yeah.
All righty. Well, Doctor, thank you very, very much. It was a fascinating session. Next week, folks, we're going to be hearing from two dentists about oral and maxillofacial surgery. Until then, have a great week. Take care. Bye bye.
Thank
Good
you. Have a
night.
good night.